Hello everyone, I hope and I believe you all are doing great. This is Dr. Arya, your pathology faculty. Today we will be studying about a very important topic, the topic of chronic bronchitis. Now what happens in the chronic bronchitis? You need to see that if the person says that, doctor, I am having a productive cough. If there is a productive cough for more than or equal to 3 months, then you have to make a diagnosis of your chronic bronchitis. Okay, and also, you know what? The tuberculosis also resembles to this case. What is the epidemiology? It peaks at the age of 60 to 40 years, and males are more prone to it, common in associated with smokers, right? What is the etiology and risk factors? First one is very important, smoking. What happens in smoking? When the person smokes, there is the chronic irritation. There is chronic irritation to what? To the bronchial mucosa. I'll draw a figure for you all. Like these are your lungs. These are your beautiful, beautiful two lungs. Then what happens is you have a mucosal layer, right? You have a mucosal layer. So what happens is when the person smokes, like these are the fumes coming out of the smokes. These are your smoke, cigarette, okay? When the person smokes a cigarette, what happens is this lining of your lung gets disrupted, okay? As a result of which, what happens? There is hypertrophy and there is hyperplasia. As a result of which, what happens now? There are certain cilia. You know what are cilia? Cilia are for your locomotion, right? So when the person smokes, what happens? The cilia also get disrupted, as a result of which there is no locomotion in the lungs. Then what is the reason? There can be the occupational exposure. What? Like the dust, cotton, grain, cement and silica, which leads to the respiratory infection. There are certain genetic predisposition also, like the polymorphs in the gene controlling. Let's see what is the pathogenesis. In the pathogenesis, what happens? You have the smoke. Person was smoking, right? What happens is it irritates the lung. As a result of which, what was happening? There was hypertrophy and hyperplasia, and the locomotion of lungs are getting disrupted, as a result of which there is increased in the secretion. Right? You have something called as the goblet cells. So here you will be able to see a goblet cell metaplasia. Normally what happens, these goblet cells are absent in your bronchioles. What happens is if there is chronic irritation, there will be metaplasia and there will be mucus secretions, as a result of which what will happen? There will be mucociliary clearance. These are your lungs, right? You have cilia. Let's suppose these are your cilia. Here you have mucus and this is your cilia. So the mucociliary clearance means there will be a lot of gap between them that will happen, and the smoking basically paralyzes the cilia. There will be no movement of the cilia. You know, you have seen in your 11th or 12th biology lectures that there is movement in the cilia which are responsible for the motion, right? There will be inflammatory response. As a result of which, what will happen? The neutrophils and the macrophages gets activated, and there is release of what? Release of protease. After that, there will be airway remodeling. Obviously, I have given you the example of that spring. What does that spring do? When we pull that springs, after some time it get back to the normal. So this is the phenomena of air remodeling. Okay, it get back into the shape. There will be the fibrosis of bronchoalveolar wall, and there will be the narrowing of the lumen. Next, there will be VQ mismatch, as a result of which what will happen? There will be airway blockage. And the ventilated area are also narrowed, as a result of which what will happen? The airway will be blocked by the mucus, and there will be blood perfusion which continues. If the blood perfusion continues, there will be the carbon dioxide retention, and there will be hypercapnia. Hypercapnia means there will be increased in the PaCO2, partial carbon dioxide level. Okay, next, what is the morphology? So in the morphology, you have the gross feature and the microscopy. In the gross, you will be able to see congested swallow and erythematous airway. Like this, these are you have small holes, so they are very congested. They will have thick gelatinous mucus plug. In the microscopy, what will you able to see? You will be able to see that there will be hypertrophy and hyperplasia, and the, you know what? There is something called as a Reid Index. You have read about the Reid Index in your pathology lectures. Where? You have to tell me that. Okay. So, you have chronic inflammation infiltrates in your bronchial wall, then there will be fibrosis of the bronchiolar valve. Next, let's see what are the clinical features. In the clinical features, you will have a productive cough. Then, there will be dyspnea. There will be chest infection. Fatigue will be there. Cyanosis will be there. That is your blue bloaters. That is your blue bloaters. Then wheeze will be there. Prolonged expiration will be there. And clubbing can also be there. And you know how to test clubbing? You ask the patient that do both your thumbs like this, and you will be able to appreciate then that in between both the thumbs there will be some gap which will be there. This signifies that the person is not having any clubbing. Okay, and clubbings are mostly seen in the people who smoke a lot, right? Who drinks a lot. The name is also suggesting clubbing. Clubbing is related to club. Club is a place where mostly smokers and alcoholics go. Okay, what are the complications you will have? There will be the progression of this disease, then there will be recurrent infection that will occur, respiratory failure will be there, and pulmonary hypertension will be there, which will further lead to the core pulmonale, and lung carcinoma will also occur. What are the investigations you will order? The first investigations will be the pulmonary function test. In the pulmonary function test, you will be able to see that there is reduced FEV1 and there is reduced FEV1 by VC ratio. Next investigation you will order is your ABG. Then in that you will be able to see that there is respiratory acidosis, and I have earlier told you that when you do a ABG, you have 4 interpretation. Either it is metabolic alkalosis, metabolic acidosis, or respiratory alkalosis and respiratory acidosis. And you have learned this in your physiology lectures as well. Okay. Then on the chest X-ray, you will be able to appreciate a very important line called as your tram track line. In the sputum examination, you will be able to see there will be mucoid which are purulent or non-purulent. What are purulent and what is non-purulent? This means that either they may be present with that greenish discharge, or either they cannot be present with that discharge. In the CT scan, you will be able to see that the bronchial walls are basically getting thickened. What is the treatment you will do? First thing first, lifestyle modification is very important. Second thing will be your smoking cessation. Ask the person, please don't smoke. Even if it does not stop, ask him again and again, please don't smoke. Okay, one day he will listen to you. Then you have to avoid the pollutants and occupational irritants, vaccination for influenza and pneumococci. What is the pharmacological treatment? You have the bronchodilators like your beta-2 agonists, 𝗲𝗵𝗹𝗵𝗵 and salmeterol. Anticholinergics, then you have the inhaled corticosteroids and mucolytics and antibiotics. I am not discussing your pharmacological treatment in details because it will be covered in your pharma lectures, right? Next, what is the prognosis? So the prognosis, this disease is very progressive and irreversible. And the prognosis basically depends on very first thing, that is your smoking. If the person is not smoking much, then there are chances that the person will recover at a very faster rate. It also depends on the severity of airflow limitations and the presence of cor pulmonale. So this was all about this chapter. This is a very short chapter. It will be asked as a very short note, or either maybe not, it can be asked. Okay. So if you are having any sort of doubt, please feel free to reach me, feel free to DM me. Thank you so much.